You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
When every decision matters, you need trusted medical intelligence. Medscape AI synthesizes peer-reviewed evidence and Medscape's expert-validated content in seconds, delivering clinically verified answers you can trust. Join over 13 million Medscape members on the world's leading platform for clinicians. Start using Medscape AI on the web or in the Medscape app. Medscape AI, trusted medical intelligence.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for April 10th, 2026. This week, 3 imaging-guided PCI trials, 2 with surprising results, LDL-targets, an oral PCSK9 inhibitor, and another beta-blocker withdrawal trial. Let's start with the first IVUS-Guided PCI trials. IVUS is intravascular ultrasound. 2 trials presented at ACC, both published in the New England Journal of Medicine, failed to find benefit from this IVUS-Guided PCI. The Optimal trial studied IVUS in left main disease, and the IVUS-CHIP trial enrolled patients with complex high-risk PCI. I think what's most striking about this story is the enthusiasm for imaging amongst many proponents who I watch online. You get the sense that imaging is the right thing to do if you are a good cardiologist. Now, I'm not an interventionalist, I'm an electrophysiologist, so I approach this from an evidence angle, and oh boy is there an interesting angle. The teaser is that evidence may have expiration dates, and more on that at the end. First the studies, then the past studies, then the evidence story. Optimal randomized about 800 patients with unprotected left main suitable for PCI. It was done in Italy, Spain, and the UK, and about half the patients had ACS. The syntax score of these patients was quite high at 30, higher than in the left main trials Excel and Noble, by the way. It was a pre- and post-IVUS versus angio-guided study. The primary endpoint was any stroke plus any MI or any revascularization or death from any cause, so a typical MACE endpoint. The first finding was that the mean procedure duration was longer in the IVUS arm, 88 versus 64 minutes. Complication rates, however, were similar. The main results, here it is, 33.7% of patients had primary endpoint in the IVUS arm, versus 30.9% in the angio arm. That's a hazard ratio of 1.11. The 95% confidence intervals went from 0.87 to 1.42, so it's obviously not significant. In fact, though, 3% worse in the IVUS arm. Well, 3% absolute risk reduction if you're doing a number needed to harm is only 35. The most notable component of the primary endpoint was stroke at 3% versus 1% in the IVUS versus control arm. Stent thrombosis was even higher, 0.7 versus 0.2%. But again, there were only 3 versus 1 patient with stent thrombosis in a trial with 800 patients. Okay, that trial is clearly non-significant, but let's do IVUS-CHIP. IVUS-CHIP randomized more patients, 2,000 patients from 7 European centers. Patients had complex coronary disease lesions. This included severe calcification, osteal lesions, bifurcation, left main, CTO, in-stent restenosis, or long lesions, or a planned PCI with mechanical circulatory support. The syntax score here was slightly lower at 25 versus 30 in Optimal. In IVUS-CHIP, 42% of patients had severe calcification. Both trials used an everolimus-eluting platinum chromium stent. The comparison in IVUS-CHIP was IVUS-guided versus angio, and they had really good fidelity to the comparison. Only 0.9% had IVUS used in the control arm. The primary endpoint was target vessel failure, and that's defined as a number of different things, including death from cardiac causes, target vessel MI, and clinically indicated target vessel revascularization. And the results were similar to Optimal. 13.9% of patients in the IVUS arm versus 11.1% in the angio arm. That's 1.25 higher rate of primary endpoints in the IVUS arm. The 95% confidence intervals of that 1.25 were quite close to significant at 0.97 to 1.60. Clearly not better, but like I said, very close, a p-value of 0.08 to worse. Most components were worse in the IVUS arm. Here, the absolute risk increase was corresponding to a N number needed to harm of 35. Definite or probable stent thrombosis, however, went the other way. In IVUS CHIP, it was lower in the IVUS arm, 0.2% versus 1.0%, but the numbers were small. It was 5 versus 15 and not enough to move the primary endpoint. Periprocedural complications were similar. So my comments, I think we should just pause for a second. 2 large RCTs. Imaging was no better, and both studies had strong trends for it being worse. I think this is fascinating, isn't it? In the European guidelines from 2024, there's a Class 1A recommendation for imaging to guide PCI. In other words, you should do it. If you don't do it, you are breaking with standard of care. Yet, when you look at the trials over time, I think you see a pattern. The early trials, done mostly in Asia, around the times of 2013 to 2018, were strongly positive. The more recent trials note a decrease in the relative risk reduction. In the most recent trial, the Illumin-4 trial of OCT imaging versus angio failed to find a difference in target vessel failure in 2,500 patients. It actually wasn't even close. So the last 3 trials, with a total of 5,300 patients randomized, has failed to find any signal of benefit of imaging-guided PCI. That's interesting. Here's what I see. The earlier trials were positive because people were learning how imaging helped inform proper stent technique. I think the corollary in my field of EP is when I learned to do transeptal heart catheterization, I used imaging, and the intracardiac echo was invaluable. Well, after hundreds, maybe thousands of transeptal heart catheterizations, you get a feel for it. ICE has taught you something, but now it becomes less helpful. I don't need the imaging for transeptal, and if I worked in Europe, I wouldn't use it. I only use ICE now because if I had a complication, an American doctor would tell a jury I was breaking the standard of care. So in my opinion, it's highly likely that the 2 recent trials done in expert centers where doctors have used imaging to guide stenting for years, they are now better at understanding the key features of stenting, and the imaging is no longer as beneficial in regular complex cases. Now I say regular cases because another thing to consider with these studies is that it's possible that the trials selected for patients with lesions that docs felt were randomizable. So as it is in many trials, it's possible that some of the toughest cases were not randomized. And had they been included, these super tough cases, you may have seen a benefit from the imaging. Maybe. This is post-hoc speculation, though, and it's just that. You don't know. Now, keep in mind that imaging isn't free. It's an extra artery cannulation. It takes time. It costs more. And the 3 most recent trials now have found no benefit. And to me, this means that the guidelines should downgrade the recommendation to a 2A or 2B and let operators choose when to use it based on their discretion. And I think the evidence-based medicine lesson is that evidence should have an expiration date. The earlier imaging trials were positive, but things have changed over time, and new trials are often needed to test new techniques inside of these new treatment environments. Now, I want to warn you about one trick that proponents may try, because there are proponents for imaging. Here's a trick they may try. You should oppose it in the strongest terms, and this is the temptation to meta-analyze all the imaging trials. This has been done in the ICD world, where the positive old ICT trials dominate and outweigh the newer negative trials, like Danish, for instance. So in the case of imaging-guided PCI, I don't doubt that a meta-analysis of all the trials, the earlier trials, would pull some of the summed effect to the positive, as it does in the ICD trials. But this is wrong-headed. You can't combine trials from 2 errors. It's not informative, and it should be resisted in all areas of cardiology. Now, before I move on, there's one small caveat to my story that I just told you, and that is another trial that was presented at ACC called the DK Crush 8 trial. This was an RCT in 24 centers in China. 555 patients who had complex bifurcation lesions were randomized to IVUS or angiography-guided PCI, and patients' PCI was going to be this double-kissing stent technique, which to this nerd-true Martian like me seems scary because a patient forever for the rest of his or her life has bare metal meeting blood platelets at the bifurcation. The primary endpoint of the DK-CRUSH-8 trial was target vessel failure, defined in the usual way as CV death, target vessel MI, or clinically driven target vessel revascularization. And this occurred in 6.1% in the IVUS arm versus a much higher rate, 14.7% at 1 year. That's a total of 17 versus 41 patients. It's a massive 60% relative risk reduction, which was highly significant. It was driven mostly by reductions in target vessel MI and target vessel revascularization. So on the surface, this positive imaging trial seems like it opposes the non-significant optimal and IVUS CHIP trials that I just told you about. But I don't think so, for two reasons. One, a different disease and two, different trial environments. So a bifurcation lesion is more complex. It's complex squared, I guess. In the procedure section of the paper, the authors tell us that the IVUS was used in 6 sequential steps of the procedure. That's a lot of potential for an image to help. For instance, they write that after balloon crushing, IVUS detected incomplete crushing in 28% of patients, all of whom underwent repeat high-pressure dilatation with a larger balloon. That may not have been seen with angiography. The second issue is the Chinese trial environment. Here, in this trial, the operators were required to have done 20 DK procedures, but the trial did not select for operators who routinely used IVUS while doing the DK PCI. So isn't it possible that the angiography arm accurately reflects routine practice, and the high event rate of 14.7% actually sort of conforms with that? And if this is true, it may be the opposite of optimal and IVUS CHIP, namely that in those trials you had super experienced operators whose skills were honed by ultrasound. But in DK-CRUSH-8, the angio-only arm reflects standard world practice. And given the complexity of both the bifurcation lesions and the DK-CRUSH procedure itself, adding ultrasound may have made a big difference. Now, the authors broke down outcomes based on optimal PCI versus suboptimal PCI in the IVUS group. And optimal results were obtained in 70% of the 277 patients in the ultrasound arm. In those patients, the target vessel failure rate was only 2.6% versus 14.7% in the angio-guided strategy. That's an even greater reduction than the main results. And crucially, in 30% of patients with suboptimal PCI results, the rates of target vessel failure were 15.9 versus 14.7%, so no benefit. I think this is a really nice sub-analysis because it provides a direct mechanistic reason why ultrasound may have helped. So I guess that the conclusion would be that if you're doing a DK-CRUSH procedure of a bifurcation lesion, then this trial strongly supports the extra imaging. It's different from the 2 previously non-significant trials. One question I have, though, is why aren't these patients with bifurcation lesions or left main lesions having coronary bypass surgery? All right, well, that's another topic. Next topic is the Ez-PAVE trial. This was low versus very low LDL targets. Now, the recent North American lipid guidelines that really caused a stir have numerous Class 1 recommendations, but nary a handful of these recommendations are backed by RCT level evidence. Now, one of these Class 1 recommendations is to target LDL cholesterol as low as 55 milligrams per deciliter. Even though the writers cite level of evidence A for RCTs, I went and looked. None of the RCTs, Improve It, Fourier, Odyssey, Fourier-Olay, tested targets. These trials tested additional agents as add-ons to statins. The 55 milligram per deciliter number is simply a post hoc observation. But at ACC, we heard results of a trial testing the specific targets of less than 70 or less than 55 milligrams per deciliter. This was the South Korean Ez-PAVE RCT, and New England Journal of Medicine published it. This trial randomly assigned slightly more than 3,000 patients who had established atherosclerotic vascular disease to an intensive LDL cholesterol target of less than 55 or a control target of less than 70. Now, how to get to that target was pragmatic and left up to the clinicians. The primary advice from the trial was to increase the statin intensity or add ezetimibe. PCSK9 inhibitor use was very limited. Patients were 64 years old and about a third had had prior MI. More than half had previously undergone coronary stenting. The mean LDL cholesterol at baseline was just 75 to 77 milligrams per deciliter. At the trial start, more than 90% of these patients were on a statin and nearly one-third were already on ezetimibe. Now, the first key finding was that the intensive arm had a median LDL cholesterol of 56 milligrams per deciliter versus 66 in the control arm. Now, I didn't misspeak. Pause there. The difference in LDL cholesterol level was 10 milligrams per deciliter. Not 100, like you lowered your LDL from 200 to 100, just 10 milligrams per deciliter. Now I'll tell you the primary endpoint, which was a composite of CV death, MI, stroke, any revascularization, or hospitalization for unstable angina. At 3 years, the more intensive LDL cholesterol group had a 33% lower rate of primary outcome events, 6.6% versus 9.7%. That hazard ratio is 0.67, and it was highly significant. The 3.1% absolute risk reduction equates to a number needed to treat of 32. Now, my friends, this sounds amazing, doesn't it? Finally, direct evidence for treating to a lower target, a 33% reduction in a MACE endpoint. Well, hold on, I'm not so sure. The components of this composite endpoint tell an important story. The driver of the positive result was the softest endpoint. The revascularization rate was 4.8% in the intensive group versus 7.5% in the control group. That hazard ratio was 0.63 and was significant. MI occurred slightly less frequently in the intensive arm at 0.8 versus 1.7%, but no other endpoint significantly differed. Most importantly, the rates of CV death and all-cause death were nearly the same. In the New England Journal of Medicine and at the meeting, the authors and the editorialists concluded that these findings provide randomized evidence supporting more intensive lipid-lowering strategies for secondary prevention consistent with the current guideline recommendations. Okay, my comments. I don't think they should jump to this conclusion. Here are a few reasons why I would be cautious about this ambitious trial. The first problem is that I'm not sure it's a plausible finding. Control arm LDL 66, intensive arm LDL 56. How does a 10 milligram per deciliter difference amount to anything substantial in terms of outcomes? Now, the cholesterol treatment trialist collaboration makes much of their meta-analysis of 170,000 patients wherein they found a 22% relative risk reduction every 39 milligrams per deciliter drop in LDL cholesterol. So if you just do fractions and you scale that down to 10 milligram per deciliter that was observed in this trial, you would expect a 5 to 6% relative risk reduction at best, not 33%. Now, I heard one theory that East Asians may have a threshold where 66 is just blah, but 56 is amazing and shreds vascular disease. But that's hard to believe, and if you believe something like that, you might even believe that left atrial appendage closure provides a net benefit to people. Now, another person I talked to about this asked whether we have to have plausible mechanisms. I mean, don't trials just test what works and what doesn't? To this, I would say yes, this is somewhat true. You may not need plausibility when a new drug reduces hard outcomes in multiple trials, such as the SGLT2 inhibitor class in heart failure with reduced ejection fraction. But in the case of Ez-PAVE, it was the decision to do revascularization that drove the benefit, not an MI or a stroke or a cardiovascular death. Which brings me to the endpoint of revascularization itself. This endpoint requires a clinician to decide the patient should have it. In this trial, as it is in many pragmatic trials, the treating docs know the patient's assignment. They would have to know because they are targeting a lower LDL cholesterol. So knowing the treatment assignment may affect the decision to recommend more angiography in the control arm. That's not nefarious, that's just clinical medicine. Another issue, and again, it's the same problem in most, if not all, pragmatic trials. The patients in the intensive arm get more therapy, not just LDL cholesterol lowering. They get higher intensity statins, which could have greater pleiotropic effects. They get more ezetimibe and more PCSK9. That makes me wonder whether this is an LDL cholesterol comparison or simply a trial of more drug versus less drug. The positive result with the softest endpoint, plus a lot of uncertainty, is a real dilemma, isn't it? Meaning, we need more trials to prove what we do is beneficial in medicine, and pragmatic trials simulate what is done in real practice. But the problem comes in isolating the causal effects of the treatment. Now, contrast pragmatic trials versus the stricter blinded trials in narrowly selected patients and narrowly selected environments. The strict trials are far better at sorting the true effect, but then these trials are harder to generalize. Pragmatic trials are easier to generalize, but then it's harder to know what is driving the benefit. Is it more therapy, more interactions with healthcare, or is it actually the target? In this case, I don't think Ez-PAVE should increase our enthusiasm for super low targets in every high-risk patient. It's not free to go lower, right? It requires more drug, more test, more attention, and more time of being a patient. And we should only increase the work of being a patient when there is strong evidence of benefit. I think doctors should always be mindful that our patients don't live to be patients. And so, in motivated, selected patients, it could be reasonable to go lower with more therapy, but there should not be a Class 1 recommendation which says we should do it in all high-risk patients. I wrote a column on this trial, and it's up at theheart.org Medscape Cardiology. Now, what about add-on therapies to statins? There may soon be a new kid on the block making a strong debut. This is called the CORALreef AddOn trial. In February, the New England Journal of Medicine published the CORALreef lipids study of the new oral PCSK9 inhibitor called enlicitide versus placebo in patients who have either a history of atherosclerotic event with an LDL cholesterol greater than 55, or patients at high risk for a first atherosclerotic event and an LDL cholesterol level of 70 or higher. Basically, high-risk patients who you want to go lower. So the mean percentage change in LDL cholesterol at week 24 was minus 57% with enlicitide versus plus 3% with placebo. In that trial, reductions in non-HDL cholesterol, apolipoprotein B, and lipoprotein(a) were also significantly greater with enlicitide. But at ACC, we heard results of the CORALreef AddOn study of similar patients who were randomized to enlicitide versus bempedoic acid versus ezetimibe versus bempedoic acid-ezetimibe combination. The trial question here was that in patients who have this risk and are on statins, and you want to go lower, what is the best add-on therapy to get lower? And the primary endpoint were lipid levels. This was not an outcomes trial, but the results were remarkable. The mean LDL cholesterol change with enlicitide was minus 64.6%. That's versus minus 6% with bempedoic acid, minus 28% with ezetimibe, and minus 36 with the ezetimibe and bempedoic acid combination. So enlicitide was superior to each comparator, all highly statistically significant. And similar to the first enlicitide trial, there were reductions in ApoB and non-HDL cholesterol were also greater in the enlicitide group than the other comparators. And proportion of patients with adverse events and or discontinuations due to adverse events were similar across treatment arms. So my comments. Clearly, the oral PCSK9 inhibitor was superior at lowering LDL cholesterol. Both ezetimibe and bempedoic acid have positive outcome trials, albeit with substantial numbers of caveats. And enlicitide does not yet have such outcome data. The CORALreef outcomes trial has completed enrollment of 14,500 patients, and its results are anticipated, but not till 2029. Enlicitide is not yet FDA approved, though in December the FDA awarded enlicitide a Commissioner's National Priority Voucher, so-called CNPV. This is a program designed to accelerate the review and approval of novel products that address large unmet medical needs. This might mean FDA approval later this year. Now, you could argue that it's probably not going to be much more effective than the injectable PCSK9 inhibitors, and I would respond to that by saying it's still better to have an oral pill than an injectable. It's just easier to take a daily pill, number one. And number two, it's interesting, with this much LDL reduction, you wonder whether the CV outcomes reduction might be substantial. So if lower is the goal, clearly this drug, enlicitide, is going to be more effective as an add-on to statins than ezetimibe or bempedoic acid. The question, though, of goal LDL cholesterol goes back to my discussion of the Ez-PAVE trial, which had top-line findings of benefit from a less than 55 versus less than 70 goal. But Ez-PAVE had caveats, and the question will remain, if you have a patient with high atherosclerotic risk who has an LDL of 69, is it really worth adding another costly drug? That's a question. I don't know the answer. Another question, and this is another one I don't know the answer, is if you have patients who are intolerant of statins, would enlicitide be the best alternative? Again, oral, once a day. I'm not sure. I'm asking. Okay, next topic is another post-MI beta blocker withdrawal study. This one's called the SMART Decision Trial. It was open-label, non-inferiority trial in 25 centers in South Korea comparing MACE outcomes in 2,500 post-MI patients who had a left ventricular ejection fraction of more than 40%. These patients had been on beta blocker for some time, at least a year from MI, the median time 4.7 years, and they were randomized to discontinuation or continuation. The primary endpoint was death, MI, or hospitalization for heart failure, and the discontinuation arm was tested with non-inferiority. The trial was similar to the French IVUS trial, only SMART Decision included only hard endpoints, whereas IVUS included revascularization as an endpoint. The decision on the primary endpoint is probably why there's a difference in outcomes. In SMART Decision, non-inferiority margin was set as a rate ratio of 1.40. At a median of 3 years of follow-up, the primary endpoint occurred in 7.2 versus 9.0% discontinuation versus continuation. That hazard ratio was 0.80, confidence intervals 0.57 to 1.13, and since the upper bound of the 95% confidence interval of 1.13 is less than 1.4, it meets non-inferiority quite easily. Numerically, every component trended in favor of the discontinuation arm, including all-cause death 2.4 versus 3.4, and stroke 0.7 versus 1.8. Serious adverse events were similar between groups. Now, this was a different result from the IVUS trial, which randomized 3,700 post-MI patients into a continuation or discontinuation arm, and in IVUS numerically favored continuation of beta blocker. Here in IVUS, it was 23.8 versus 21.1, and the 2.1% higher rate in the stopping arm corresponded to a hazard ratio of 1.16, with 95% confidence intervals going from 1.01 to 1.33, and that did not make non-inferiority. Clearly, it was higher in the beta blocker discontinuation arm in IVUS. So on the surface, it looks like we have different results from SMART Decision. But I think it has to do with the choice of endpoints. In IVUS, the driver of the higher rates of events in the stopping arm corresponded to a higher rate of cardiovascular hospitalizations. It was 18.9 versus 16.6. The most common reason for hospitalization was for angiography, which was 2.3% higher in the stopping arm. One interesting aspect of the SMART Decision trial is that they had an exploratory IVUS-like composite endpoint of death, MI, stroke, or hospitalization for cardiovascular cause, but in SMART Decision, it still favored discontinuation, 11.0 versus 14.5%. So my take of the IVUS trial, and I've written about this before in a column, is that all hard clinical endpoints, death, MI, stroke, were nearly identical. So, if IVUS had counted the same clinical endpoints as all the other beta blocker withdrawal trials, it would have produced similar results. So my comments. I think the beta blocker after MI with preserved ejection fraction story has reached the level of coffee studies. That is, we don't need any more trials to tell us that the general routine beta blocker usage after MI is not helpful. Smart decision along with the BIS tell us that discontinuation after months or years is fine. Reboot, reduce AMI, BETAMI, DanBlock, and Kaplan RCT tell us that early use of beta blocker also does not lead to benefit. So as it is with aspirin for primary prevention and likely the preventive ICD, the post-MI beta blocker reversal story is yet more evidence that evidence should have an expiration date. Old data was fine during old times, but when times change, this means new evidence is needed. Now, I'm not saying that we should never use beta blockers after MI. Sometimes there's a good reason. Let's say the patient has atrial fibrillation with a rapid rate and you want a beta blocker for rate control. That's fine. What we're talking about here is the routine mandated use of beta blocker for reduction of CV outcomes. It just looks to be not the case anymore. So finally, there's way more to discuss from ACC, but I've gone on long enough this week. There was another RCT of posterior wall isolation as an addition to PVI to discuss, but there's not enough time for today. Later this afternoon, I fly from Louisville to Paris for the European Heart Rhythm Association meeting. I'm looking forward to seeing my friends and doing the 5K on Monday. I have a session on statistics and trial shenanigans at 1600 on Sunday if you are there and want to come. Sadly, 1600 hours on Sunday will be when one of the best bike races of the year finishes just a few miles north of Paris in Roubaix, so I'm going to have to watch the Paris-Roubaix race on tape delay. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.